Welcome to Thought Leadership for the New Normal, a conversation series with Sacred Heart University deans. This week we ask our panel of experts, how is this crisis changing how hospitals are serving their patients? Join us now live from the campus of Sacred Heart University with your host, Randy Kay.
Welcome, and thank you so much for joining us today. I am Randy Kay, and this is our fourth episode, and today we're talking about hospitals. Specifically in this crisis, how hospitals are serving their patients. Is the crisis changing it? And I'd like to welcome my guest today. First in studio, we have Dr. Mary Alice Donius. She's Dean of the Davis and Henley College of Nursing at Sacred Heart University. Welcome, Mary Alice.
Thank you, Randy. I'm excited to be here.
I'm so glad to have you. And on Skype, joining us on Skype, we have Keith Hovan, President and CEO of South Coast Healthcare Systems. Welcome, Keith.
Thank you. Pleasure to be with you.
So great. And this is the South Coast of where, just so we know?
Massachusetts.
Okay, thank you. There's a lot of South Coast in this country. I'm going to start a conversation with you, Mary Alice. Nurses. Do you see nurses as the first line in a pandemic?
Oh, absolutely. Absolutely, Randy. The first people they see are the staff nurses that are in the hospital, there to welcome and guide the patients through the experience. They're an incredible group of men and women right now who are honored in all sorts of ways, from the banging of pots and pans and from the apartments of New York City to
7 p.m.
To all kinds of recognition. But they are the heart and soul of healthcare in the hospitals, and not alone, but with a variety of interprofessionals. But clearly, staff nurses are the backbone of this epidemic. And then we see opportunities for primary care providers, for nurse practitioners of all sites, to be able to offer care and triage patients, give primary care opportunities through patient contact, through telehealth. There's all kinds of opportunities now for staff nurses and advanced practice nurses to shine and do what they do.
You know, having been into the emergency room a few times in my life, I can say that that's absolutely true, not to put down doctors who are equally important, but definitely the first line. Keith, do you have anything to add to that?
Well, I would completely agree with what you're saying. You know, the core response that we have had to this pandemic really has been based on the care and the incredible services provided by all of our nurses, including our advanced practice professionals. We had even seen advanced practice professionals who primarily worked in outpatient settings come into the hospitals and partner with their colleagues in the intensive care units, in the emergency departments, to help us manage with the incredible patient volumes that we were seeing. So nursing has been at the core of our response, and they've been great partners for all of our physicians and other providers.
Thank you. And we'll talk very soon about the training of these nurses, which is, of course, what you do. And in this crisis, I can't even imagine. Keith, how has the pandemic disrupted the delivery of care in general? And how do you think the pandemic has further connected South Coast to the community?
Great question. So the disruption has been absolutely unprecedented. And I know that word has been used a lot during this crisis, but we saw a complete disruption of all of our elective procedures and our elective business. People stopped coming in for everything from routine mammograms and colonoscopies to even routine surgeries, some of which we normally would be considering somewhat time sensitive. We have moved from the high touch physical locations that we normally would provide care in to telemedicine being provided for many of our patient visits. An interesting statistic for us was that we had anticipated that between 2 and 4% of all the care that we delivered on a primary care basis would happen via telemedicine, during 2020. What we saw by the time we were 6 weeks into the pandemic was that 96% of all of our primary care, over 5,000 visits a day, were being delivered by telemedicine. So the rate of change has been absolutely unprecedented. The movement of patients from inpatient to outpatient settings has certainly been accelerated, and we have seen just really a complete disruption of what we considered the old normal. Now you asked the question about the
Percentage, and you got 96. Did you say 2 to 5%?
2 to 4%. So we thought 2 would be doing good, 4 would be knocking it out of the park. And part of that was based on our perception that patients really wanted to be seen in person. Part of that was based on our provider preferences in not performing their services over a computer. And the whole system got turned upside down within just a matter of weeks. And I suspect that there really is no going back anymore.
Keith, did you see that the providers were well prepared to use telemedicine or telehealth strategies and technology? I know we're incorporating it immediately into our content in both the undergraduate and graduate programs, but did you have to train people, or were they well prepared?
Did. So we had providers that provided some of their care via telemedicine already, but it was a small fraction of what they did. Those providers were able to ramp up and see more patients much more quickly than others. We had some who needed some at-the-elbow support to be able to get through it, but everybody moved relatively quickly into that format. And some of our biggest naysayers and the folks who said, "I'll never see a patient over the internet," became the biggest advocates for telemedicine. So it was really remarkable to see.
It's amazing what comes out of crisis. It truly is. So you started to talk about training. So let's talk about that. How do you think preparing our nursing students has changed? And has this altered nursing education and students' access to clinical opportunities? Talk more about that.
Very much so. And first I want to compliment my own faculty, both undergraduate and graduate faculty, for turning on a dime. When mid-March and things started to completely fall apart, our faculty put everything they could online and virtual clinicals. And the remarkable outcomes are significant. Students passed the courses, and the clinicals were really canceled mid-March for all of our students, and that was a very difficult experience. However, I think now, as the crisis has continued, agencies are seeing the value of having student nurses return to the clinical areas, not to take care of the COVID patients, but to give some relief to the nurses who are
overworked,
taking care of non-COVID patients. Right. Students are quite capable of that. So I think in the fall we anticipate sending all of our students back to the agencies for clinical placement, perhaps in smaller groups with faculty, and perhaps in more concentrated or immersion experiences that can provide care over a longer period of time or a sequence of days. The graduate students have pretty much been able to maintain their clinical placements. The nurse practitioners are finding the same difficulty as the undergraduate pre-licensure students, but everything is working out, and the value of students in practice settings is being recognized.
So they're desperately needed. Those clinical placements are important. Are there you mentioned social distancing. Of course, everybody takes precautions in a hospital setting. Are there further precautions that the students are taking when they go into clinical placements?
Yes. All of the PPE, all of the personal protective equipment will be required of the students. And the school, the College of Nursing, is providing all of that PPE for the student so that they have it to go into the clinical, and we don't expect the agencies to supply that protective equipment. Also, I think our nursing students are leading a way of role modeling how we need to be in the world now, because they understand that their connections on the outside, they have to protect not only themselves, but they have to protect their patients. So I think of all of the on-campus students that will be back, our nursing students will be role modeling how to behave in common spaces, how to wear masks when you're outside.
Not under the nose, but over the nose, right?
And hand washing, of course. And we do have all kinds of social distancing in the classrooms and where we can in the clinical laboratories on campus. But those clinical laboratories then are set up differently for PPE, face masks, and face shields.
How quickly we have all changed to adapt to this. It feels, I've been thinking about this, as we all have, a lot lately, and we thought this would be a little battle, like a couple of weeks, maybe a couple of months, and now it feels like a war. I'm not going to compare it to, sending people off to World War II, but it feels like it might be 18 months before, we make that adjustment, and in wartime, of course, we have to adjust very quickly, and that's what I've seen in all the conversations we've had. Everybody amazingly, adjusting quickly, doing what has to be done. I've seen so much bravery and so much resilience. It's been amazing. Thank you. Keith, my next question is for you. Let's talk about politics. I mean, we know the wearing of masks has a bit of politics to it, but let's specifically about our healthcare organization. Has politics helped or hurt the healthcare organization's response to the pandemic? Was the triage of patients an inadvertent way of rationing care?
So I could speak from the Massachusetts experience, where I think the state organized an incredibly robust response. Our legislative delegation, got on the phone with us every single week. So we've had weekly calls with our entire delegation to update them with regard to the status of our organization, our needs for everything from laboratory testing to PPE. We've had daily calls with our governor to talk about the status of all the major hospitals within the Commonwealth, so that we could make sure that we were coordinating where resources were going to be applied, where field hospitals would be set up, and so that all citizens would have equal access to the resources that they needed, whether it be in testing, emergency care and services, hospitalization, or even convalescence. So I can tell you that I had the opportunity to bear witness to some of the very best of politics, small and big P, coming together to really do the right thing for individuals who had needs. So it's been a remarkable experience up here in Massachusetts.
That's wonderful to hear, because very often you don't get that answer, and it just goes to show you what good leadership, good political leadership can do. You're in Massachusetts. In Connecticut, have you found politics to have any effect on what you do?
Well, I think I live in New York and I work in Connecticut, so I have two state perspectives.
Because all our governors are talking to each other and coordinating care, which has been
wonderful.
Great.
And I commend New York, particularly with the outbreak in New Rochelle initially, and that really did save a lot of lives, I think. In Connecticut, again, I do sit on a board in Connecticut, and the connection with the governor's office and the leadership of healthcare in Connecticut has been remarkable. And I applaud all of them for their thoughtful decisions and their willingness to listen and to react to the changes that occur almost daily.
Wow. Politics at its best.
Exactly.
Politics at its best. You heard it here, and that's so refreshing to hear. Thank you. But we also mentioned about triage. Was there anything you wanted to add, or you, Keith, that was part of the question? Is triage,
So
does it have a role in the selection and inadvertent way of rationing care?
our biggest concern was that we were going to have to triage. When we looked at the Italian experience, we started to count our ventilators. We started to survey our entire organization to look for places that we could deploy additional ICU beds, and we could put additional patients if we needed to. So we actually went out and we were able to secure more than 2 times the number of ventilators that we would normally have in a given year. We were able to expand our ICU capacity 3-fold. And then we worked with the state and the Massachusetts Emergency Management Agency. We took a gym from one of our local universities. We set up an additional 100 beds for overflow. So that when the hospitals became full, we would have a place to admit patients. And the good news is that we were always able to manage without having to turn anybody away, without having to make any, rationing decisions. We were working with our clinical leaders. We actually brought in a Harvard medical ethicist to help us think through what it might be like if we came to the point where we had to make triage decisions. And I can tell you there probably wasn't a dry eye in that conference room as we talked through it. But we didn't have to. In fact, we, having opened up the 100 beds in that field hospital, never needed to admit anybody to the field hospital. Our hospitals ran very full, and our triage system, within the hospitals, was working 24 hours a day, 7 days a week, being coordinated by our chief operating officer in the command center. But we managed through it very successfully. And I think part of that really was a function of, again, getting back to politics, our local leaders, our mayors, our town managers, working with us to communicate to the public to stay home, to wear a face mask, to wash your hands, to avoid being in large groups, to stay out of the nursing homes, and to visit your loved ones via telephone or Skype or some alternative methods. So we had just a tremendous response from our community that really, I think, helped keep our numbers in a controllable way.
That's wonderful to hear. Thank you. Mary Alice, what has this done to the future of nursing? How do you see the future of nursing, RNs and APRNs?
Mm-hmm. Well, I think first it's really brought home the value and an appreciation for the role of the nurse, no matter where or how or how prepared. A nurse is not necessarily a nurse is a nurse, but I think as nurse as a collective, society has begun to understand and appreciate their value as individuals and as a collective. This was the designated Year of the Nurse by by WHO. And it was announced in September, and it's amazing. I don't think anyone thought that this was the year that was going to unfold as the Year of the Nurse, but it certainly has. What I see in our students, particularly our undergraduate students, is that they're eager to get out there. Our seniors graduating, there's apprehension, there's caution, but this is what they've been prepared for, and they're excited about it. I think it's made them think about where they want to go to work. Their questions on interview are different. Their expectations for their orientations are different.
Can you elaborate on that? What do you mean, their questions?
Well, I think they're looking, how are you going to keep me safe so I can keep the patient safe? How are you going to prepare me in an orientation in which I am well prepared to do the work that I'm expected to do? With all of the focus on COVID and the COVID patients. Our faculty have done a great job in helping the students understand what they're going to be facing in this new reality. So that was part of preparing our undergrads for the work world. I think we see, too, in terms of undergraduate enrollment, people really thinking about the decision to become a nurse now that this is part of their reality. And for some, it's just confirms it. It strengthens their commitment. It strengthens their confidence to be a nurse. And in other cases, it causes pause to reflect, to see, is this really the best way I can help? Is this the best helping profession for me to enter? So I think we're seeing some of those reactions and some of those responses, especially at the undergraduate level. For those who are nurses, I think they're looking at career options that maybe they hadn't thought about before, like infection control or quality improvement, of epidemiology, and the role of an advanced practice nurse who can develop more specialized skills and be more available and helpful to patients. So I think it's going to strengthen nursing as a collective, and I think it's going to give some individuals in nursing a very different direction than they thought.
Okay, maybe in a more specialized area, or maybe some people going, maybe this isn't what I wanted, and it weeds them out in a way. Crisis does that.
Yeah, I think it just helps them to reflect on what they need to be fulfilled in a career, and the risks that they're willing to take, not just for themselves but for their families. And sometimes that might not be the appropriate risk at this time. It doesn't mean that it's not available to them at any other time.
Right. Yeah. All right. Thank you. That makes a lot of sense. I think in a lot of the public professions, people are weighing those issues.
Yeah, absolutely.
You know,
and
do I endanger my family by helping other people? And they should, as you say. All right. Keith, how do you envision using nurses in the future, and whether or not the pandemic has altered how you intend to deploy healthcare professionals maybe in a different way in the future?
So I think the thing that we've witnessed around the country is that our public health infrastructure is woefully inadequate and it's weak. I believe there is a role that nurses can play in the pre-hospital setting, in the community, to help us manage populations, to help us keep people healthy, to keep people safe so that they don't need to come to the hospital. And I think Mary Alice is really touched on that with the role of the advanced practice nurse, managing populations of patients of their own panels of patients, that they could, not just help to maintain an optimal level of wellness, but to also create a level of prevention so that we don't see things like this happening as we move into the future. But the impact of nursing and the impact of the clinicians that I've witnessed throughout our organization over the last 3 or 4 months has been just remarkable. I made it a point every day in every chance that I got to put on a mask and go out and round. And when I would round, I'd start in my ICUs, I'd go to the COVID units, and I'd stop in the ED because those were the hardest hit, places within our organization. And what I had the opportunity to witness and to hear from our clinicians, in particular our nurses, I of course want to find out how they were doing. I'd want to talk to them about our patients. I'd want to, join them for rounds. But I'd also want to say thank you for all that they were doing, because many of them were putting in many, many extra hours. And consistently, the message that I heard from our nursing staff was, you don't have to thank us. We got this. This is what we trained for. This is what we do. And we feel privileged to be here. And it was really, really moving to be out there on the floors and to see, how sick some of these patients were. And these nurses were at it day in and day out. And it was just absolutely remarkable.
That makes me cry a little bit.
Yeah.
Providers are affecting the delivery of care now, and how will they in the future?
So clearly, before this pandemic struck, we were seeing a transition into a more retail-based model for care delivery, right? So CVS had set up its minute clinics and had nurse practitioners, seeing non-urgent care and providing vaccinations and medical advice, in many of their pharmacies. And I suspect we're going to continue to see that play out in, organizations like CVS. I think organizations like ours will continue to also embrace that model. In southeastern Massachusetts, we've opened up a series of urgent care centers because we recognize that people, don't want to have to come to the emergency department for something that could be managed in an alternative setting, and they shouldn't have to, right? They shouldn't have to come to the ED, and they shouldn't have to pay the kinds of copays and fees that they would otherwise see coming through an ED. So we have a retail-based model that complements what our primary care and other ambulatory-based physician practices do. Now we have telemedicine, and I believe telemedicine and virtual medicine is here to stay. And I believe that patients want to receive the care from their local provider, but they want to receive the care conveniently. They want to receive the care that they need in a manner that just makes it easy for them. And I think that we've got to endeavor to continue to do that and to listen to our patients, hear what they want, and then meet them, where they're coming from. So I think, we already started down the path of change. I believe the pandemic, really accelerated the adoption of some of these new technologies and these new approaches to managing care. And I think providers are going to increasingly be at risk for managing populations. And when I say risk, I mean financial risk, and seeing budgets being established for taking care of a population. And it's the right thing to do to keep people at their optimal state of wellness and to keep them out of the hospitals. And then ultimately, I think providers, community, and society will be rewarded if we do just that.
Thank you. So I'm aware what CVS does. I know that they, sometimes have nurses and they're sort of a walk-in clinic, but what is Amazon doing for delivery of care? It's something new to me.
So I can't speak with any authority on Amazon's approach to care. And I think some of that is really yet to reveal itself. We know that Amazon is one of 3 partner companies that got together to form a new venture to be a disruptor in the healthcare delivery market. So I don't think we've come to appreciate. Amazon was a huge disruptor and continues to be a huge disruptor to kind of normal supply chains. Whether you're talking about buying a book or paper towels, you could get it all on Amazon. So we'll see where they actually go with their new venture. I can tell you that before the pandemic struck, Amazon was selling intensive care units in a container, meaning like a trucking container that you could have purchased for $275,000 and had delivered to your home. So if they can do that, I'm sure they will figure out new and creative ways to keep us all on our toes.
I didn't know that. Does it just drive up and unfold and the staff comes out to welcome you?
I guess so. Well, you see, Amazon just always grasps the opportunities. We talked a bit about the future of nursing and how this crisis has affected some of your and their decisions. How has it affected the way you train them? Has there been a difference in the way you train them?
I think there's no greater disruptor than the pandemic, especially for now, for education and for healthcare, as all industries, I'm sure. But it has. In our planning for the fall, and I know many of our faculty may be not watching this because they're terribly consumed with preparing their courses for the fall, but we're introducing something across the university called ShoeFlex, which is being able to welcome students back on campus for full
Shoe meaning SHU,
Yeah.
Sacred Heart
Yeah.
University, not shoes you wear on your
Right,
feet,
right,
just,
right,
in
right.
case somebody's
That's
watching in
true.
Arizona or something. Okay.
But the idea is we're ready to welcome all students back on campus, keeping them safe, keeping to the CDC guidelines, the Connecticut guidelines, but also able to turn on a dime if we need to return to online teaching, if we need to use virtual clinicals in our case, or how do we keep our students safe here in the Connecticut region in order to complete their clinicals. So we're looking at a great deal of operational pieces. Internally, in terms of content, it really has changed some of the ways in which we think about bringing those consequences of the pandemic to the classroom and bringing them alive for the students to understand that this is one virus. The likelihood in their lifetime of career, they'll see many, many more. So how we respond to this and how it unfolds and the kinds of things that are coming out of it to support vaccines, to support patient care, to support different delivery of care is also part of the conversation. So not just the day-to-day operations of making sure the curriculum is met, but also helping the students understand where they see themselves in this offering of nursing to society in general.
Okay, thank you. So we're all learning about how to respond better, how to prevent better. And before we close this episode, I just want to ask if either one of you has anything you'd like to add that I haven't asked you. Keith, I'll start with you. Anything, any final words on this subject of this crisis and the healthcare industry?
Sure. So from my perspective, the thing that I didn't expect was the response that we received from our community. And I know we've been talking a lot about education training and our nursing staff, but our community has been just unbelievably supportive. From the local boat yards who called up and said, we have N95 masks that we use to paint the hulls of boats. Do you need some? To people who wanted to cook for our providers and bring food to them. But the outpouring of support from our local community was just unexpected, and it was heartwarming and it was just remarkable. So, I think while this pandemic is testing us, while it's stressing our supply chain, while it certainly is having an incredible adverse impact on finances, both at the personal level in people's households and really on a national level in terms of the economy, it really has, in some respects, brought out the very best of humanity.
Thank you.
I would
Mary
like
Alice,
to agree with Keith on that, and also say that we developed far stronger relationships with our clinical partners as a result of this. We were asked almost immediately if we had any extra masks and gowns and gloves that could be provided to staff. And since we were not holding any clinical laboratory sessions, we gave all of our equipment to the local hospitals and hospices that requested them. And now when we're going back to ask for that relationship to offer clinical sites for our students, there's a much different understanding of how we are in this all together and how we cooperate and collaborate for the benefit of patients and society as a whole.
Wonderful. Thank you. I keep thinking, no one is an island, no one stands alone. Throughout all these episodes, it has come so clear, even more clear, that how much we need each other and how people step up to help. I always feel if people know what to do and you tell them how to help, they want to. And when we hear so much bad news, it's always good to hear the good news. So Keith and Mary Alice, thank you so much for joining us today. Thank you.
Pleasure.
This has been episode 4 of our series, Thought Leadership for the New Normal, a conversation series with Sacred Heart University deans and other experts. It's sponsored by Sacred Heart University and WSHU. I'm Randy Kay.
Thank you for joining today's conversation. Join us next week as we look at what healthcare will look like in the year ahead, all a part of our thought leadership for the new normal.